Uh, all right, you have a patient, patient 8 in the GYN list. She has abnormal uterine bleeding, uh, polyp ovulatory dysfunction, and class 2 obesity. How do you, and I see you did a hysteroscopy DNC, how would you manage this patient? Like, what are her management options besides a hysteroscopy DNC? Does she have any other options?
So for patients who are over 45 with abnormal uterine bleeding, I always want to do a some type of sampling for the patient. So even if the patient wants just only medical management, I still want to do a sampling of the uterine lining to rule out cancer. For these patients with polyps, I do tell them that because the polyp is a focal disease pathology, sometimes the biopsy cannot adequately sample the pathology. So even if the biopsy comes back negative or normal, we're not entirely sure that the polyp is benign. So for these patients, I still suggest doing a hysteroscopy DNC and
What's
remove the
the
polyp.
sensitivity of an endometrial biopsy?
I believe for generalized pathology, it's about 80%.
And how much of the endometrium do you sample? Like, do you sample what percentage of the endometrium?
Yeah, I believe the only sample is about 10%.
Okay. And then walk me through like an endometrial like biopsy. How do you do one? What are your steps?
You mean like an office one?
Yes.
So I will have a patient lay supine in a lithotomy position. I will put in a speculum with a light source, um, and then I would clean the cervix with betadine. Then I will grasp the anterior lip of the cervix, and then I will use a dilator to dilate the cervix um, to an adequate size, and then I would try
What if
to.
you start? What if you start dilating her cervix and the patient gets really like upset and so much pain? How would you manage her pain right then and there? Or like, what would you do right then and there?
Okay. We do have lidocaine in the office, so I can offer the patient with some paracervical uh, anesthesia by injecting at 6 and 9 o'clock with the like a
Would you
quarter.
consent your patient for that before you do it?
Of course, I will talk to the patient
Okay.
beforehand and make sure she's okay with that.
Okay. Okay. And then how do you perform the biopsy? What like instrument do you use?
So I use uh, a small gauge pipelle, and I will insert the pipelle all the way to the fundus, and then I would do multiple passages with the pipelle to get enough sample.
Okay, case
Usually,
number 9. Okay, case number 9. Sorry
okay.
to interrupt, but
No, you're good.
case number 9. Yeah, I have a patient with postmenopausal bleeding after hormone injection, unsuccessful office biopsy, and then let's say the same patient comes in with a thickened endometrium that's 18 millimeters, but she's not complaining of postmenopausal bleeding. Is there any risk that she has for is there any risk that she has for like uh, abnormal endometrial findings? And would you do an endometrial biopsy even if she's not
Uh,
having bleeding?
yeah. So With patients who has a thickened endometrium greater than 11 millimeters, even if the patient is not bleeding, I would still offer her a endometrial sampling because I would counsel the patient that the risk of her having endometrial pathology at that thickness is the same as someone who has abnormal urine bleeding with a much less
Okay, case number 18. You have this patient with AGUS. What is AGUS and how did you manage this patient?
uh, AGUS is atypical glandular uh, atypical glandular tissue with undetermined significance.
Okay.
For these patients, I usually counsel them that sometimes the glandular tissue can be from the endometrium. So I will counsel these patients to have endometrial biopsy as well as a colposcopy to sample their endometrium.
Do you do anything besides a colposcopy and an endometrial biopsy? Do you do an ECC on them?
I do ECC on all my colposcopies. So yes.
On all your colposcopies. Okay. And let's say the same scenario, patient had AGUS, but she was 33 years old. How would you counsel her? Would you manage her the same way?
Uh, yes, I would still do an endometrial biopsy.
Okay, case number 17. You have this patient you took to the OR who had a uterine perforation. Walk me at the time uh, why it happened, or like how it happened. How did you recognize it, and how did you manage the perforation?
So this patient uh, is slightly obese, so she had a lot of redundant vaginal tissue, so the exposure wasn't the best during her surgery. So after I had prepped the patient and put in a speculum, I had my assistant to retract her vaginal sidewalls, and after a slightly difficult dilation of her cervix, when I put in the hysteroscopy, I noticed a small fundal perforation when I introduced the hysteroscope. And at that point, I aborted the procedure. I was able to take some pictures while I had the hysteroscope in there.
Mm.
So I had those pictures sent to a oncologist who had suggested that she be seen by them due to the findings on the pictures. Um, and so this patient went to an oncologist, um, and she was found to have a low-grade endometrial cancer. Um, and
Oh,
she
wow.
had a TLH BSO with lymph node biopsy and sampling done by the
Wow. Okay.
oncologist. Yeah.
All right. Let's say so you started. So you recognized the perforation before you even started the surgery. Let's say you were doing. Is that correct? Is that what happened?
Correct. Yes.
Correct. Okay, let's say you were doing the hysteroscopy. You went in, you were performing your sampling, and your fluid deficit went from 500 to 2,000. How would you proceed? And then when you were looking, you recognized there was a perforation on like the lateral wall of the uterus. How would you proceed? Tell me, how would you manage this? What would you do?
Yeah, so in that case, due to the high level of deficits, I would first want to talk to anesthesia to make sure patient is currently stable, uh, and then because it's a lateral perforation, I am more concerned about uh, perforating a blood vessel. So in this case,
Like what? Like what blood vessel?
like a uterine ascending uterine artery. Um, so I would most likely convert her into a laparoscopy to take a look from the inside to make sure there's no broad ligament hematoma developing. Um, yeah.
Okay, and is that everything you would do? Let's say her fluid deficit instead of 2,000 was 3,000. It shot up from what it was when you were working to 3,000. How would you manage that?
I would uh, have anesthesia draw up some lab work, mainly a CMP and also a CBC since I'm concerned about hemorrhage, um, and then also just monitor the patient uh, to see if inpatient to make sure she doesn't develop any signs of hyponatremia and also any volume overload. I will consider giving this patient Lasix to help with diuresis. Um, if the uh, if the lab if the CMP comes back and her sodium is below 120, I will consider giving her 3% um, hypertonic normal saline.
How do you administer that?
I believe it's 100 cc's in the first hour, um, and then we can reassess if she has any symptoms, uh, or you can redraw the labs, and then if it's still low, then you can give another 100 cc's. But I would try to not correct it too fast, so I would consider only giving her about 400 cc's to bring up her sodium about 10
What are
milliequivalents.
Why would you not want to correct her too fast?
There is a slight risk of central pontine myelinitis if you
Mhm.
correct hyponatremia too fast.
Okay. All right. And then we have sorry. And like you did mention, this is the last question. And you did mention you're worried about injury to the uterine artery. What is the uterine artery a branch of? And can you name some of the other branches of that vessel?
Yeah, so uterine artery is a branch of the hypogastric artery, or the anterior division of the inferior iliac, or is it inferior?
Internal iliac.
Internal internal iliac artery.
Okay.
So the other branches of the internal iliac will include the obliterated umbilical artery, um, the superior vesical artery, the vaginal artery, uterine artery, uh, operator artery, inferior gluteal. I think I'm missing a couple.
Pudendal,
Yes, the internal pudendal.
inferior vesicle.
Oh, superior and inferior vesicle.
Yeah,
Oh,
they
okay,
both
okay,
are from there. Yeah.
got it. Yeah. So yeah, so it's eight, right?
All right, cool, nice, man, and you did really good. And just, I think one thing, what was the when I asked you, yeah, if a patient's 33 years old with AGUS,
Mm-hmm.
they say if the patient's more than 35, you should go ahead and sample the endometrium. But if she's less than 35, you should assess for risk factors for like anovulation or like endometrial like hyperplasia, like like chronic anovulation, obesity, PCOS, things like that. Then you would go ahead and sample.
Wait,
So
I thought
just
that was
okay.
for if you had like endometrial tissue or like endometrial cells.
That's if you have glandular cells on your pap.
Oh, isn't
Like,
let me
like if
I'll
it's
have to double check on that. Cause
yeah, if it
but you know what I'm talking about? Like if sometimes you
yeah,
have like the endometrial cells, but they're
mhm.
not like atypical glandular. You know what I'm saying?
Yeah. Oh yeah, yeah. I think yeah.
But
I think
that's
from
like
my understanding,
when you're
it's
45, right? You have to sample them.
35,
Is it
35,
35?
35. Yeah, it's for. I think what I'm talking about is like if you have a pap with atypical glandular cells, either like NOS or like highly suggestive of malignancy or US, like like undetermined significance, because there's a higher chance of like adenocarcinoma with these patients and like
Mm-hmm.
CIS and stuff. And that's why they're more careful. And if the sampling, if you do like all that workup, if you do a colpo ECC and a like EMB and it's negative, how would you follow them afterwards? Would you just like go back to like routine screening, like every three
Wait,
or 5 years?
say that again.
So if someone comes in with like AGC and
Uh-huh.
you do or like AGUS, that's the question that I wanted to ask you actually. But
Uh-huh.
if you do your workup, if you do the
Uh-huh.
ECC, colpo, and the EMB, and everything comes back negative, how would you follow them after?
I would repeat it 1 year.
So they say to like repeat it at 12 and 24 months,
Uh-huh.
and if that is negative, you can go to Q3 Q3 testing via co-test. But if there's any like abnormality, then you should like manage it accordingly. Yeah.
Okay. So no more every 5 years.
Yeah, exactly, exactly. Yeah. So that's a pearl. I think that was a pearl. And it's also in that preparation manual, like one of the manuals they gave us. There's the case, the structured cases manual. It's like the first part of the office. They go over like all these scenarios with like the pap smears and stuff. You should read it actually. That manual is a lot of help. The one with the structured cases
Uh, from the
from
structured
Exam
case.
Pro.
Oh, like the one that's like a lot of words. Is that the one?
Yeah, so many words. Yeah,
Do you
yeah.
remember
There's
what
so
page
many.
it was on?
Yeah, yeah. Let me see. I
Is it-
actually have it. It's in a different room, but I can look at.
Okay. No,
I
no,
can go
that's
take
fine.
a look now. You want to pull up my kids list? Start.
Yeah, let me
Yeah.
hold on.
How's the baby doing?
Crying.
Crying. Well, now you're at home all the time, right? You're off. You're not working these days.
No, I'm back to work.
Oh, you're back to work.
Yeah, I took 2 weeks. I'm sure
Nice.
they don't wanted me to take more.
Yeah, no, I'm surprised they gave you 2 weeks, dude.
I
Yeah,
mean,
that's
like,
nice.
I don't think they have a choice. I wanted two
Um,
weeks. I have so many vacations saved up.
nice.
Yeah.
What's the? Yeah, I'll look up the. It's here somewhere. But I'll look it up and I'll send you the page for it. But this is also there. You go. AGUSNOS. Yes. So there it is. With squamous lesion in women over 30 with glandular lesions. Okay. Yeah, it's page 195.
Okay. I'll look it
Yeah.
up later. Let me
Yeah,
I can do that later. Let me quiz you,
sure,
okay?
sure.
Let's see. So I have bunch of random questions all over the place. So
Yeah, yeah.
let's do
Go.
your OB first.
Sure.
Let's see. Patient 102 OB.
Mhm.
Did we do this one?
I don't remember. Let me pull up my list. 102. 102.
Yeah.
There we go.
So what's your
Yeah.
what you did? We did?
No, I went over it with someone else. Yeah.
Oh, okay. So what is prolonged fetal bradycardia?
So prolonged fetal bradycardia is defined as a fetal heart rate of less than 100 beats per minute that lasts for 2 minutes or more. Uh, yeah.
Okay. So what's bradycardia?
Bradycardia is a fetal heart rate that is less than 100 minutes, but not for as long as 2 minutes. Like it doesn't exceed the 2 minute duration.
So so after 2 minutes it comes back. It's bradycardia. So let's say the fetal heart rate drops to below 90, and then it comes back before it hits 2 minutes. Is that a bradycardia or is it not a bradycardia?
It's a deceleration. Depending how quickly the fetal heart rate returns back to baseline, it could be considered a variable deceleration, or it could be considered uh, 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 a period of fetal bradycardia. And things I would look out to, and things I would be concerned about at the time of this happening to would be a shift of baseline in the fetal heart rate.
Okay. Um, and then so this patient also has cholestasis of pregnancy. Can you tell me what if this patient has cholestasis of pregnancy, how would you when would you deliver this patient?
So cholestasis of pregnancy can be delivered as early as 36 weeks, but if the bile acids are not severely elevated, if they're not more than 40, or if the liver function tests are not severely elevated as well, they're not showing an abnormality, and if the fetal heart rate, the fetal growth is reassuring, and the patient has no other comorbidities with the pregnancy, such as preeclampsia um, or or anything else, I think I can consider delivery at a later gestational age, before 39 weeks, and this was the case with this patient. She had very mild elevation in her bile acids. They were less than 20, but more than 10. And her antenatal testing was reassuring during prenatal care, and she didn't have any other comorbidities. And the decision was made to deliver her at that gestational age was made with in conjunction with my maternal fetal medicine colleagues.
Okay, so below 40 you would do uh somewhere between 38 to 39. Is that what you're saying?
No later than 39 weeks. Yeah.
Okay. What if it's between 40 and 100?
I would consider delivery at an earlier gestational age than 38 to 39, so maybe by 37 to 38, or possibly sooner, depending on the clinical situation as well and the circumstances.
Okay. Patient 104. Alright, so this patient was found to have chorio on the placental pathology.
Mhm.
So did you treat this patient during labor?
This patient was not treated in labor as she wasn't showing any signs of chorioamnionitis at the time of delivery. She didn't have any clinical signs or symptoms of it, so she was not treated. This was a histopathological diagnosis with no clinical consequence.
Okay. So, okay. So this one patient is a vacuum assisted vaginal delivery. What kind of vacuum do you use, doctor?
I usually use the Kiwi OmniCup vacuum in my practice.
Okay. Can you tell me how you apply the vacuum?
Yes. So first of all, my safety checklist would include the following. I would make sure that the patient is fully dilated, that the fetal station is 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 at +2, that the patient has adequate like anesthesia, pain management via an epidural or what have you, some of the other options. And I would also make sure that the patient's bladder and rectum are evacuated. I would also consent the patient regarding the procedure, review the risks with her, and I would also inform the staff on labor and delivery that we're doing a vacuum-assisted delivery, and with failure of that, we may need to do a C-section, and I would make them aware of that possibility. I would also review the indications of the vacuum-assisted delivery, and for this case, it was done for a non-reassuring fetal heart tracing during the second stage of labor. And then I would confirm the presentation of the fetus. I would confirm the position of the fetus, and I would then apply the Kiwi cup vacuum on the flexion point, which is located around 2 centimeters anterior to the posterior fontanelle. I would make sure when I apply the Kiwi vacuum cup that I don't include any vaginal or cervical mucosa in that. Um, and then I would increase the pressure on the Kiwi vacuum cup to the green zone, which is somewhere that should be between 400 and 600 millimeters mercury. And I would then instruct the patient to push while gentle traction is applied in in the in a direction that would facilitate the descent of the fetal head and the delivery of the fetal head through the pelvic outlet, and that would be a direction that would be downwards and slightly upwards, and I would avoid any rocking movements uh, while while applying traction on the vacuum. And once the fetal head is low enough at +3 station, I would then remove the vacuum and then deliver the fetal head with the assistance of by utilizing the modified Ritgen's maneuver. Uh, and
Okay.
then once I
No, that's
and then
fine.
once I'm okay.
What are some of the complications of a vacuum delivery?
So, complications of the vacuum delivery include fetal and maternal. For the maternal side, you can have extensive perineal lacerations that may involve the external anal sphincter, or even that may go through to include the rectal mucosa, which would be a third or a fourth degree vaginal laceration. And with those tears, there's a higher chance of uh, future fetal incontinence, sexual dysfunction, dyspareunia, and psychological trauma. For the fetus, there's a risk of injury to the newborn. There may be uh, and an injury to some of the veins draining the scalp that may cause a cephalic hematoma or a subgaleal hemorrhage. And the bleeding may also, in very severe cases or in fetuses with coagulopathies and bleeding disorders, there may be an intraventricular hemorrhage, and it may even involve a subconjunctival hemorrhage in very severe cases. There may be also some like lacerations to the scalp, superficial lacerations to the fetal scalp, and those are the complications that I can remember at this time.
What happens if the patient has a subgaleal, or not a patient? What happens if the neonate has a subgaleal hemorrhage?
That's an emergency. It's a serious complication of an operative vaginal delivery, and I believe the prognosis is not. The prognosis can be very severe, and hence immediate recognition and management of this is required. However, in my practice, I do not usually deal with that complication personally, and I wouldn't know how to manage it entirely, and I will need to look that up.
Okay. And do you know where the separation is that causes subgaleal hemorrhage?
Yes, I believe it's below the level of the dura of the brain, and that's why it poses an increased risk because it's very close to the brain.
Below the dura.
I believe so.
Okay. Isn't dura in the brain?
Yes.
Okay. So this is an intracranial hemorrhage.
I will have to look that up.
Okay. All right, let's move on. Let's see. Oh, I forgot to ask you, how do you manage chorio? What medication do you start her on?
I give AMP and Gent. AMP is 2 grams Q6, and gentamicin is 5 milligrams per kg Q24 hours. And I do that either for 24 hours or until the patient is at febrile for 24 hours.
Okay.
If that is diagnosed during labor.
And what if the patient is penicillin allergic?
Depending on the allergy to penicillin, if it's a severe allergy that would cause anaphylaxis or angioedema or something, I would probably consider an alternative antibiotic to ampicillin, such as clindamycin, for example. And if it is a non-severe allergy, I can administer, such as hives or a rash, I would administer Ansef.
Okay.
Which is cefazolin. Yeah, it's really hard, like, not to use trade names.
I don't think it will matter.
Yeah. Okay.
Yeah. What if you had to take her to the OR for C-section? Would you do anything different?
If the patient had ruptured membranes, I would add
She has chorio.
azithromycin.
Right.
Yeah, I would add 1 dose of azithromycin, 500 milligrams, prior to incision.
So you're gonna do AMP and GENT and azithromycin?
Yes.
Okay. Let's see. 105. Okay, so this patient had postpartum hemorrhage. They had to give her blood transfusion. What's the difference between cryo versus FFP?
I think FFP, fresh frozen plasma, contains clotting, contains contains all the clotting factors that are found in the serum, as well as small amounts of fibrinogen and plasma, and Cryo contains it's a concentrate of factor 8.
Does cryo have fibrinogen?
Uh, I'm not sure. I will have to look that up, but I don't think it does.
Okay. Let's see. And when would you give one over the other?
I would give fresh frozen plasma routinely. I give it routinely during a massive transfusion protocol, or in cases of DIC where a patient is bleeding profusely and I'm concerned about a consumptive coagulopathy. I would utilize fresh frozen plasma. For patients of postpartum hemorrhage where a massive transfusion protocol was already initiated with minimal improvement in the patient's status, I would consider cryo at that time as a management to DNC to DIC.
Okay. 110, patient 110. So this patient had a third degree laceration, 3C. So what is the 3C third degree laceration?
So 3C is a laceration of the external anal sphincter that would go through the entire thickness of the external anal sphincter, and it may include a portion of the internal anal sphincter as well. But it doesn't go through the rectal mucosa.
Okay. Would you repair the internal anal sphincter if it was damaged?
I would place multiple overlapping sutures over the external anal sphincter, and that should in turn approximate the fibers of the internal anal sphincter and should promote its healing. I wouldn't repair the fibers of the internal anal sphincter separately unless there's a fourth degree perineal laceration.
Okay. What antibiotics did you give in this case? It says you gave IV antibiotics.
110. So this patient had So this patient received 1 dose of cefazolin, 2 grams, following the diagnosis and the repair of the third degree laceration.
Okay. Let's see. Next. Alright. Did you try? Okay, 113.
Mm-hmm.
113 transfers back down. Looks like you made a classical incision. Would you try anything before you make a classical incision on this patient?
So this is a patient who was a late transfer of care to us, and I saw her for one time in the office, like a few days before her scheduled C-section with me, and I just wanted to counsel her about the circumstances of her case. This being her first her first full-term pregnancy. She had like a multiple fibroid uterus, and there was very limited like options for me to manage her besides the way I did manage her. For a patient like her, I wouldn't attempt an external cephalic version, given that she had a multiple fibroid uterus, severe iron deficiency anemia, limited prenatal care, and there was a very high risk for a complication happening if I attempted an ECV on her.
Okay. Let's say she doesn't have a fibroid. How would you manage her differently?
Oh, she doesn't have fibroid. Yeah, I would then counsel her about her management options. I would include the option of ECV in my management options, given that she is aware of the complications and the chances of success are about 50%. And with the failure of the ECV, we would proceed with a cesarean delivery. Uh, as a vaginal delivery would be associated with lesser bleeding, infection, and a quicker recovery to the patient as well.
Let's say before you so a classical C-section is the only thing she can get. There's no other options for her
That
or
was
any other things you could try beforehand before you make
that
a classical C-section.
Yeah, there was the intra the intraoperative findings for this patient did not allow for me to do anything besides a classical cesarean section. Also,
I
given
mean,
that the
I mean
baby.
for someone who doesn't have a fibroid. Let's say she doesn't have
Oh,
a fibroid, and she comes
oh, and
in with
she's
transverse
transverse
back
back
down.
down.
Correct.
Oh yeah. Yeah. Usually for transverse back down, uh, I would be I would be more mindful that a classical incision or a classical C-section may be associated with a lower risk of trauma and injury to the fetus, and as well as difficulty with delivery of the fetus following the performance of the hysterotomy. Just because uh, if if I perform a low transverse incision on the uterus, there won't be any fetal parts for me to grab when I try to deliver the baby. But with a classical C-section, it would allow that to happen easier for me to deliver the baby. Uh, I can I can attempt to do a low transverse incision on the lower uterine segment and possibly extend it through an inverted T, but that would be more traumatic for the patient.
What's the risk of rupture after a classical C-section?
It can be as high as 10% with a future pregnancy.
Okay. All right. Let's go over it.
That's it.
Yep.
Okay, how did I do?
No, it was good.
Okay.
Um, let's see. So the transfers back down. Actually, I think you can also try to like before you make the uterine hysterotomy, you can try
Mm.
to vert the patient into a breech. That way you
Oh, into a
can
breach. Oh.
right, because
Mm.
you can it's easier to manipulate the uterus.
And the buttocks too. Yeah, because it's bigger.
Yeah, exactly.
Mm.
When the patient is already open, so it's like after a C-section. So after you made the incision into the abdomen,
Mm.
you can try to avert the baby into a breech position, and then you just deliver, like a breech.
Like a breach. Yeah, I think I
Right.
had one of those. If you go to my last page on my case list, there was a lady. Yeah, so
Let me see.
case 253. It says fetal malpresentation, but she had like a transverse
Oh, okay.
back down too, and then she had a low transverse incision, and then she had an injury to the left broad ligament. So I know, man. But this
Yeah.
lady, was her
No, no,
first baby. I didn't want to give her a classical,
yeah.
but that one with the fibroid,
No,
that was
no,
the
with the
only
fibroid, no, there's
really,
no way you can do
yeah.
anything.
Right.
But
No way, yeah.
but yeah, that's what I was trying to get you to say, because I was trying
Right,
to,
right.
yeah, but yeah. All right, so let's just work our way up. So I asked you about the
There's just like a higher chance of injury, I think, if you do the what do you call it? If you do like a low transverse and you try to turn the baby, just because there's the
no,
baby's
no,
back
you
there.
do it
Yeah.
you do it before you make the hysterotomy.
Oh, yeah. Okay.
Yeah,
Yeah,
on
that's smart. That should be smarter. Yeah.
yeah. I mean, like if it doesn't work, then you still do a classical. But like if it
Right.
works, then you can do a low transfers.
Mm.
Let's see. So we talked about that one, and then the 3C. I don't think there's anything for that one. You did pretty well on that one. So cryo versus FFP. So FFP
Yeah.
is there's like a table in one of the books, and
Yeah. I know. Yeah. I know that
yeah.
table.
So cryo does have fibrinogen.
Mm.
Um, so FFP is like 240 cc's versus cryo is only like 50 cc's. So
Mm.
if you're worried about volume overloading, you can use cryo
Mm.
instead of FFP to bring up the fibrinogen. FFP has quite a bit of fibrinogen actually. So
Mm.
um, yeah, but that's one way to use cryo. The other way is if the patient has von Willebrand's, you
Mm.
can give cryo for the
Right.
factor 8. So those are
Mm.
the two ways to use cryo. Um,
I thought about Von Willebrand, but I didn't say it. But because I wasn't sure if it was like factor eight or not. But I guess it is, right? Yeah.
yeah.
Okay.
Uh-huh.
Mm.
Uh, let's see. Choreo. You did choreo fine. So if they're on amp and gent, and they're
Mm.
going for a C-section, I think you're supposed to add clinda as well. It's
Linda.
either
Mm.
clinda or metronidazole,
Yeah.
and then
And
plus
triples. Like you do triples for like 24 hours or something. Like you continue that or.
if it's choreo, you just give one additional dose.
Okay.
And then if it's endometritis, then you
Mm.
continue for 24 hours until
Got
afib,
it.
right?
Okay. And
Uh,
so do you do the flagell and the azithro too? Or she's on enough antibiotics, I'm assuming. She won't need
yeah, I
it.
think
Yeah,
I don't think you need a zither anymore after
right.
that. Yeah.
And when do you
Uh,
give azithro? Just for someone who's like laboring and like ruptured,
mm-hmm.
and you're taking her for a section, you just give her one dose of azithro, and
Yeah.
that's the to prophylax like against like endometritis, right?
I don't know why, but I know it decreases the postpartum infection
And
rate.
infection. Yeah, right.
Yeah, but
Cool.
yeah. I
Yeah,
don't
yeah.
know why, but just give it.
Cool.
Yeah. And then we talked about the um what's it called? The vacuum.
Yeah.
Um, so for the vacuum, what you said about how to apply it, you said you take it off at +3. I think it should be +5.
That's plus five, dude.
Yeah, cause plus
Yeah.
some people, I mean, sometimes I apply at +3 to bring it down
Right.
more. So
Sure,
plus,
sure, sure.
cause the way you're saying it is like you're bringing from +2 to +3. That's only 1 centimeter.
Hmm. Yeah, probably more than that. Probably
Yeah.
plus
So
plus
plus
four.
5 is at the antroides, like that. You can see the head,
Got
right?
it. Yeah.
That's why.
Yeah, that's
That's
what I do.
where.
Yeah. Mhm.
Yeah. That's +5. So you should be taking it off at that time, not +3.
Cool.
Um, and then what else did I say about? Oh, so subgaleal. Um, I don't know if you have up to date, but there's
Uh-huh.
like a really good picture of like all the different types of head injuries
Mm-hmm.
from like a vacuum delivery. Hold on,
Mm-hmm.
let me take a look. So a subgaleal hemorrhage is actually outside of the scalp.
Jura.
Yeah,
Oh, okay.
dura's dura is
Skull.
the right, yeah, dura is
Mm.
part of the brain. right?
Mhm.
So subgaleal is actually right under the scalp. It's between the galea aponeurosis, and the what is it called? The skull periosteum.
Periosteum. Okay.
Yeah.
Yeah.
So
And like the emissory veins are injured, right? Is that correct?
the
Or,
what?
uh, emissory veins,
Em, emis-
EMISSARY.
that I'm not sure. It's
Okay.
definitely the veins. Yes.
Okay.
Yeah. And then so it's dangerous because it can cross suture lines.
Okay.
That's why it can bleed a lot. Because
Mhm.
versus like a cephalohematoma, it's under the periosteum, so it's inside the skull. It's inside the skull, so it doesn't expand.
Oh, okay.
So it's between the skull and the periosteum, so it stays in the skull, so it doesn't expand.
Oh, so it's deeper actually.
It's
Ah,
deeper, right?
yeah.
So
Okay.
subgaleal is actually a little bit
More
more
superficial. Yeah.
superficial, right? It's between the
Mm,
scalp and the skull. So there's
got it.
just like a lot of veins there that can easily tear and bleed. Yeah.
Mhm. Cool.
So yeah, that's so actually to treat. There's nothing really you can do to treat that. It's just supportive
Mm,
management and give them blood. Hopefully it stops. There's not much you can do.
yeah.
That's why the mortality rate is so high.
Yeah.
Uh-huh.
Did you have one of those?
No, I'm
No,
just
thank God.
just
Yeah.
reading about it.
Yeah, that's a very bad complication, man.
Mm-hmm.
I hope it never happens to anyone.
Right. And then also one other complication I think you forgot to mention was intra um what do you call that? The bleeding into the eyes. Um,
Oh, subconjunctival hemorrhage. I said subconjunctival hemorrhage,
oh,
but I'm not sure if there's like
retinal hemorrhage.
retinal hemorrhage.
Yeah,
Right,
retinal
right. Okay,
hemorrhage. Yeah.
okay.
Uh, so that's that one. And then okay, so cholestasis. So greater than 100, you deliver at 36. 40 to 100 is 37. At less than 40, deliver 38. That's it.
Okay,
Yeah.
good.
And
Do you go
then
beyond 39? Like not beyond
no,
39
no,
weeks?
38 to
Yeah,
39.
just
39
38.
is
30
the
is
39
the
is the
cutoff.
the cutoff.
Right,
Yeah.
right. Yeah, okay.
And so bradycardia. I don't know if that's a actual term. Prolonged bradycardia. I think
Uh, Like a prolonged D cell, basically.
yeah, this prolonged D cell is between um between 2 minutes to
2 to
10
10.
minutes is a
Right.
prolonged D cell, but once you go down to uh go below 110 is bradycardia, right? I don't think there's a prolonged bradycardia. I don't know. And you
Yeah,
can double
I mean it's
check
the
on
same
that.
thing. Yeah,
Yeah.
I'll double check on that.
Yeah. So um and then the what do you call it? So a variable is um wh- a variable D cell. So what's the definition of a variable D cell?
So it's a D cell that basically uh, the amplitude of decrease is more than 30 beats per minute, and it returns at less than 2 minutes from the start of the D cell to baseline.
So a variable D cell is basically the inverse of an acceleration. So it's more than 15 beats per minute, the amplitude, and its onset to nadir is less than 30 seconds, and then it comes back to baseline.
That's the onset to nadir is the 30 seconds. Okay.
Yeah, so it's like an abrupt decrease versus
Right.
versus a subtle late deceleration, right? It's a
Right.
it's like a it's less than 15 seconds. I mean, less
Yeah.
than 15 um, amplitude beats per minute, and
Right.
it's
Right.
more than 30 seconds
Right. There's the.
from onset to nadir,
Hmm.
and it's and occurs after the peak of the contraction.
Right. With the onset to nadir is more than 30 seconds. Right. And the one. Okay. That's right. Okay. Cool. Yeah. There's Yeah. You're right. Cool.
Yeah, because I feel like nomenclature
It's
is
very
kind of
basic.
it's very basic, but I feel like they might
Yeah.
ask you real just like to define something.
Right.
Um, but yeah, alright, I think that's it, right?
Yeah. I think so, dude.
All right. So okay, so we'll meet tomorrow too.
Tomorrow. Yeah. Sure. I just.